All right, so looking at the ACLS algorithm for Vfib VTAC, let me go through this really quick. So you start CPR, you've checked a pulse, there's no pulse, you start CPR, somebody starts bagging, you attach the monitor, the defibrillator, and you look to see if the rhythm is shockable. So if it's Vfib or VTAC, then yes, you deliver a shock. But if it's just a flat, straight line, then no shock is delivered. When you start CPR, it says push hard, at least 2 inches, and fast, about 100 to 120 per minute. Allow complete chest recoil, and minimize interruptions in compressions. So when you're switching from one person to the next, you don't take your time switching. It's like, okay, I'm tired. And then you get off the chest, you move to the side, the next person gets up, they get their hands on, and then they start compressions. And like 3 to 5 seconds have gone by, that's too long. So what they emphasize is you don't take breaks from doing compressions. And it makes a difference in whether the person converts and gets into a normal rhythm. So it says minimize interruptions and compressions and avoid excessive ventilation. So again, that's what we see written. They're claiming that when you have excessive ventilation, the air in the lungs prevents blood from flowing back to the heart because you have positive pressure in the lungs, and that's going to prevent blood returning to the heart. So that's why they're saying avoid excessive ventilation. Rotate the compressor every 2 minutes or sooner if fatigued. So 2 minutes, that's what? How many sets of compressions? 32, 34, like 8 sets of compressions, and now the next person takes over? I don't know, at the hospital you see some people going for several minutes at a time, but you do better compressions when you're not as fatigued. By the time 2 minutes is up, it's hard to do the best compressions as you did when you first started. If the patient's not intubated, then you stop for ventilations, 30 to 2. Once the patient's intubated, there is no interruption in compressions. And when you put an end-tidal CO2 adapter on there, and you can measure end-tidal CO2, when there's less than 10 millimeters mercury of CO2 coming back out of the lungs, that tells you that you don't have good perfusion and CPR isn't being done effectively. So you want to see more than 10 millimeters mercury of CO2 being exhaled. And if there's an A-line in, then you should see a good diastolic pressure as well as systolic. If it's less than 20 diastolic, then do better CPR. All right, biphasic, monophasic, we talked about. For the drug, you give epinephrine, 1 milligram every 3 to 5 minutes. And if that doesn't work, then you give amiodarone. Okay, what does it say for advanced airway? Use endotracheal intubation or a subglottic advanced airway. What is that referring to? Do you know? Subglottic airway? It does. Sorry. Supraglottic. Above the glottis. Yeah.
Is that the laryngeal mass?
Yes, very good.
What is the what? Oropharyngeal?
It's referring to the laryngeal mask airway, where there's a mask that you stick into the throat and inflate it, and it isolates just the larynx, so you ventilate the lungs only and not the stomach. LMA. And they want you to use waveform capnography in order to verify that the endotube is in the right spot. I think that's pretty much standard procedure everywhere you go. You always use end-tidal CO2 to verify tube placement. And the problem with using end-tidal CO2 to make sure that the tube is in the right spot If somebody's doing no compressions or compressions are ineffective, you don't get any CO2 coming back. So the endotube could be in the trachea, perfect placement, and yet you don't have no CO2 return. And that's because somebody's not doing compressions effectively. Maybe the person had an aneurysm and they bled out completely internally, nobody realizes it. But you could be in the right spot and not get CO2 back, just to let you know. And I think that's a test question too. All right, and then it says 1 breath every 6 seconds. Of course, when you're at the hospital, they tell you to beg faster. I think we did everything. Once you get return of spontaneous circulation, you check the pulse and then you check a blood pressure. And you should suddenly see an increase in CO2 as blood is perfusing the tissues and bringing CO2 back to the lungs. You'll see CO2 start to spike. Okay. All right, so idioventricular is a rhythm that you'll see. It originates in the ventricles, and so the rate is really slow. This is 30 to 40 per minute, and all you see are wide QRS complexes. All right, so you'll see wide QRSs and nothing else. So could you call that VTAC? Why not?
Because the rate is slow.
Because the rate is slow. So VTAC, you've got a very fast rhythm. Idioventricular is a very slow rhythm. And, okay, so it could speed up a little bit. And then asystole is absence of all electrical activity in the ventricles, and the survival rate is dismal. So Vfib, there's a better survival. Of course Vfib, better survival. Fine Vfib, less survival. Asystole, very dismal. Almost no people come back from complete asystole. So asystole is just a flat line. Can you defibrillate this or shock it?
No.
No. So if you see asystole, defibrillation is not indicated. So what could you do for asystole? You begin CPR, and you can give some epinephrine, and that's it. And then the last one is pulseless electrical activity, where the monitor shows electrical conduction, but there's no pulse. The reason for this could be that there's hypovolemia, where like a stab wound to the chest, where all the blood has left the vascular space. For the first several minutes, conduction through the heart is normal, but there's just no blood circulating. That's why you'll see normal PQRST, and there's no pulse. Patient's unresponsive. What could cause that? So it says hypovolemia, no blood volume. Hypoxia, so they've been without oxygen for a while. Really high potassium can cause that. Hypothermia, and hydrogen ions, meaning acidosis. And then there's some T's that also can cause this pulseless electrical activity. A tension pneumothorax, cardiac tamponade, a big blood clot, a thrombosis, or certain toxins.
Why is hyperkalemia for this? What does that have to do? Is it because there's so much in the cell? I know it's
So there needs to be more potassium inside the cell than outside the cell in order for depolarization to occur. If you have a whole bunch of potassium outside the cell, then now you don't get that change in polarity. And that's it. All right, should we review some strips? All right.
That's clear.
Page 353.
What page is that?
Which edition do you have? I have both editions written down. Okay, so that would be on page 316?
316?
Yes. All right, so number 3, what do you see?
Is that a 6?
Is that,
Yes, it is 6 seconds.
Okay.
junctional
Junctional.
escape rhythm?
Okay, and how could you tell? How can you tell it's a junctional escape rhythm?
Yeah, the P wave
How
is.
close we can move it?
Okay, so the P wave's inverted, which tells you what?
It's polarized the opposite way.
Yes, polarized backwards, from bottom to top.
And it's so close to the QRS.
Yes, very close to the QRS. Is the QRS normal?
Yeah.
Yes. Does the rate help you figure out that it's junctional escape? 40 to 60? All right, take a look at number 22. And tell me what you think.
22.
What page is this?
Okay, this is page 403 on the new edition, and it was page 351 on the old edition.
Idio.
Which one, number
Idioventricular.
Very good. Number 22, yes. So you don't see P waves, you see a very slow ventricular rate. The QRS is really wide. So that defines idioventricular rhythm.
So the indicators were that the QRS is really wide and the rhythm is really slow.
Yes. Kim, we need like another 10 minutes. Oh, okay. All right, what about the strip below that? What are those big, wide QRSs considered? Did you say abnormal?
Oh, that's every.
Oh no. Wait.
Hold on. That's not the
Trigen. Or it could be 3.
Well, it couldn't be tri because that would mean every third complex is a PVC.
3 in a row.
Bundle?
No, no.
So
It's
is it
not
just
3 in a row.
Premature.
Bundle? Bundle branch?
A bundle branch block, we would see like an M or a W.
Is it towards the, yeah.
If it was
It's
tortoise
not
to
tortoise.
pointus, then all of them would be
They would be
big
twisted.
wide QRSs. But we've got a bunch of normal impulses
Is it?
and just once in a while abnormal.
Is it device?
Is it bigeminy? No, that would be every other impulse. Is
just-
it PVC?
Can you only have PVC or does it have to be?
Yeah, you can only have PVCs. And that's what this is?
So it's PVC?
Yes. You can say frequent PVCs. So you have a, what is the rate? 300, 150? Maybe about 140 to 150. So we have a sinus tachycardia with frequent PVCs. This is page 354, number 8, if you have the new edition. For the old edition, it's page 316. Do you see P waves?
No.
No.
Junctional
All right, so you see that the QRS is normal, so we know that it went through the AV node and spread through the ventricles normally, but it just seems so fast to be coming from the AV node. But can that happen? Can we get a faster rate from the AV node?
Yeah.
Yeah, and it's called junctional tachycardia. Okay. Page 402, number 19. This is page 402. I need you to look at number 19.
PVC. Course.
And what is this called?
Vfib.
Very good. That's Vfib, or ventricular fibrillation, where it's just a coarse, wavy line. So what would you do in this case?
Shock for pulse. Check for
Check for a pulse. And if it's not a loose lead and this is actually the patient's rhythm, would they have a pulse with this? No, no pulse with Vfib. So what would you do then?
CPR.
CPR, shock.
Red shock.
Are you in a hurry to shock?
I am.
If they don't
Don't go to his hospital.
Never in a hurry to shock.
You're never in a hurry to shock somebody?
We do CPR first.
Yeah, the sooner you can defibrillate, the better the chances of survival. You want to be in a hurry for this.
So should you just shock first, not even do CPR, or how long should you do CPR before you shock?
As soon as the defibrillator is at the bedside is when to shock. So if somebody has to run and get the crash cart, bring it into the room, yes, you start compressions. This is page 400, number 11. And in the older edition, it's page 351. Very good. So you see a normal complex, and then you see a big wide QRS. And it's every other beat, or every other impulse. So that would be bigeminal. Page 402, number 21. This is page 402, number 21 in the new edition.
VTAC.
Yeah, and in the old edition? Okay. In the old edition, it's page 353. All right, so you see really fast, big wide QRSs. They're very regular looking. That's VTAC. Would you expect a pulse with that?
Yeah, there could be.
Possibly. Page 407, number 38. Oh, and then in the old edition? It's page 355. Number 38,
Is it a sinus block?
a sinus block?
A bundle.
Bundle branch block? No.
A PVC?
Yes. Why do they look different from each other? This one is down, it has a different shape than this one.
What is it?
It's PVCs, so it's a sinus rhythm with PVCs. But are they all coming from one ectopic site in the ventricle?
No.
No, so different ectopic sites are causing different look to the PVCs. Okay. This is number 36.
This is the 3Ds.
It's the what? The 3 Bs?
Yes.
No, that's not. It's sinus rhythm with bundle branch block.
All right, so there's no P wave.
Wrong. Wrong.
So the only thing we see are ventricular complexes. We don't see anything coming from the atrium.
So it's a pure PVC?
You would need like a sinus rhythm to go along with PVCs. This doesn't have that. It's a real slow rate. Only the ventricles are showing any conduction. Very good. Idioventricular. But what do you notice about the ventricles? Is there a bundle branch block to give it that look of W?
Yes.
Where one ventricle is depolarizing sooner than the other?
Yeah.
All right, so there's some necrotic tissue there, and it's causing half of the ventricles to take longer to depolarize, and that's why you get that W or the M.
So that's a idioventricular and a bundle branch block?
Yes. All right, page 406, number 36. Oh, that's the one we just did, never mind. What is this one? Number 6? It's on page 351 in the older edition. Yes, Vfib, very good. Number 31, this is on page 320. It's number 31 in the new edition, and page 355, number 16 on the old edition.
Big letter?
Very good. So you see the sawtooth looking pattern? So the atria are just going crazy, depolarizing, and then once in a while it conducts through to the ventricles. That's a good review, right? Okay, number 3. And this is page 355, number 16 in the old edition. And somebody said it already. Yes, this is AFib. How could you tell? Chaotic baseline.
Irregular rhythm.
Irregular R-to-R intervals. Very good. Okay. Is that good for a review?
Yes.
All right. So that's it for the day. And then we have some demonstrations to do. Did you already turn this on?